According to the World Health Organization, heart disease remains the #1 cause of death worldwide, taking more than 18 million lives every year. Yet what makes this fact so striking is that up to 80% of these deaths might be preventable. Prevention, however, requires us to look deeper than just outward fitness, looking well, or even youthfulness, as these don't necessarily equate to true cardiovascular health. And yet, what continues to shock me is that some of the most powerful tools we have to protect one of our most important organs remain underused and not spoken about. Take the Scan we'll discuss today, a non-invasive test that can reveal the hidden state of the arteries years before a crisis strikes. For many, it's the difference between prevention and catastrophe, yet outside specialist circles, it largely remains almost unknown. This is why I invited Dr. Manish Motwani to join me on Ageless today. As a leading cardiologist and physician whose work spans the full spectrum, from prevention through to emergency intervention, he sees daily the consequences of missed opportunities and the life-changing impact when patients finally take prevention seriously. We're going to differentiate between being fit and truly heart healthy, and dismantle some of the most dangerous myths around cardiovascular disease. And importantly, I'm going to share my own results so you can understand what this test really means and why it may be one of the most crucial tools for longevity that you've never heard of. And if this conversation resonates, please subscribe, review, or share it with someone you love. Mani, welcome to Ageless.
Thank you. It's my pleasure. Looking forward to it.
Let's boil it back down to basics.
Okay.
Is there a difference between heart health and heart fitness?
Yeah. So I'm going to use a prop here. So this is the heart. Okay.
Yes.
So heart health, if you like, is really about the structures of the heart. You know, is the structure of your heart normal, or are all the bits connected to where they should be? So that's what I consider heart health. Heart fitness is really how well they all work together, the performance. Okay. It's, you have a full range of cars. You have a low performance car and a high performance car. Okay. The low performance car could still be well put together. It could be very well engineered. Okay. But it's not going to perform as well as the finely tuned, trained up high performance cars.
Okay. So how can we measure heart fitness? So when you're managing patients, but also when you're working academically as well, is a measure of it heart rate variability, and how do you measure that and what does it mean?
Things you can do with lots of fancy equipment and scanners and probes and all of that.
Yeah.
Okay. But before all of that, what I will say is, what are your numbers? Do you know your numbers? Okay.
Okay.
So do you know what your blood pressure is? Do you know your resting heart rate? And the number of patients you see, they've got no idea. Okay. They know how much memory is on their iPhone. Okay. They know the spec of their computer, but they don't know their own blood pressure. They don't know the heart rate. And these are the two most basic, simple elements, of heart fitness. Okay. Most of us are using smartwatches, tell us our heart rate. Blood pressure you can get checked anytime at your GP practice, pharmacy, Tesco's, wherever. Okay. £20 for a medical grade blood pressure machine at home. Know your blood pressure, check it weekly.
Okay.
So your resting heart rate, generally healthy, is between 55 and 65 at rest whilst you're chilling. Blood pressure, you want around 120 over 75. That's a healthy blood pressure. Okay. So just knowing those two simple elements before you get into anything fancy tells you a lot about your own heart fitness.
Okay.
Then if you go a little bit more advanced, heart rate variability is something that's looked at for heart fitness. That's how well your heart can respond to stimuli. So you'd expect your heart rate to go up, if you're stressed, if you go for a run. Okay, there's no point in just staying at the same heart rate. So can your heart respond to stimuli? And also, does it slow down when you're chilling? Okay, you don't want your heart rate at 80, 90 when you're going to sleep or, sat down relaxing. So does your heart rate respond to stimuli? Can it rest? Okay. That is an indicator of fitness. Okay.
Yeah, because I see in the longevity data a lot of conversation around heart rate variability
Yeah.
as a measure. And I think from a practical perspective for listeners, people might want to know, is it helpful to know how quickly my heart rate will go down once they've been exercising?
So, you know,
Okay.
if you've been for a run, you've done some exercise,
Mm.
you'd expect your heart rate to come down by about 10% every minute or so down to your baseline.
Yeah.
Okay. I mean, ultimately, it's if you're stressed, or, you know, stress can be, you know, one example of not exercise, but it has the same kind of physiology in the sense that you've got adrenaline flowing through your body. Okay. And that will all put the heart rate up. Okay. So if you're so stressed that your heart rate is always high and doesn't dip down, you can see how heart rate variability, low heart rate variability, is an indicator of poor overall health. Okay. You want
Yes.
your heart rate to have troughs and peaks. That's perfectly normal. That's a fit heart. But just flat out at in one gear is not, you know, keeping the engine running smoothly.
Okay, so what about the amount of cardio that somebody might need? So there's so much discussion around we need to be doing X amount per week for this amount of time, that we need to be doing this amount of HIIT. But from a basic minimum perspective that people can incorporate
Yeah.
week by week, what's the lowest level of cardio that somebody might need?
If I frame it in a different way, it's actually that being totally sedentary is a risk factor. Okay. It's
Okay.
not about, you know, me doing the more exercise I do, the lower my risk. I mean, there's an element of that, but it doesn't go on exponentially. Okay. So, you know, if I run 5 miles a day versus I run 10 miles a day, I haven't halved my risk by that amount of exercise. But if I did nothing every day, that's a very high risk factor.
Risk
Okay.
factor for what?
For heart attacks, heart failure, and, you know, outside the heart, you know, all the sequelae of obesity, you know, general all-cause mortality,
Yes.
we know
Yes.
is linked to being sedentary. The recent studies have shown that, you know, 7,000 steps, it's gone down a little bit from previous recommendations, even 7,000 steps a day, just walking.
Should your heart rate be going up when you're walking?
Well, it should go up, but the more fit you get,
Yes.
the less it will go up.
And what about when people are actively trying to do some cardio?
So your target heart rate, if you like, for, you know, vigorous exercise or, you know, a good workout,
Yeah.
is the calculation of 220 minus your age. You know, that's what your heart can cope with. Okay, pushing it beyond that can sometimes be dangerous as well. Okay, so for a vigorous workout, you should be aiming for 85% of that. So 220 minus your age, 85% of that
Yep.
is your advised, you know, vigorous, high intensity workout.
I think that's a really useful and safe voice from you to actually give that recommendation, because when I'm looking at health span content, etc., I'm hearing a lot of conversations about pushing the heart consistently much higher than that. I think it's a bit of a concern. Let's get on to stress.
Okay.
You've mentioned it before.
Yeah.
I want to know the truth. How dangerous is stress to the cardiovascular system?
Stress is very dangerous. Very dangerous.
Very dangerous.
I mean, it can actually break the heart. I mean, I don't know if you've heard of this condition called stress cardiomyopathy.
Yeah.
Takotsubo cardiomyopathy.
Yep, you've taught me about it before.
Yeah, otherwise known as broken heart syndrome. Okay.
Tell me what it is.
So Takotsubo cardiomyopathy or stress cardiomyopathy, if you're exposed to a massive amount of stress, can actually stun the heart so much that it's incapacitated.
In an acute situation.
In an acute situation. So, I mean, they came across this in Japan in the 90s. And then they noticed this pattern that when there were earthquakes, they saw a surge in admissions, particularly middle-aged females, perimenopausal females.
Previously fit and well?
Previously fit, totally fit.
Okay.
And when you have a heart attack, we look at the arteries supplying the heart. So they went ahead and looked at the arteries, and the arteries were actually normal. So they couldn't work out how women were having heart attacks without any blockages in their coronary arteries. Anyway, turns out what was happening is the massive adrenaline surges that are happening as a stress response. Your body's response to stress fight, flight, danger is to produce a lot of adrenaline,
Yes.
okay, so that you can get out of there or
Yep.
whatever. That adrenaline, even though being, important to your body in massive amounts, in a supernormal amount, kind of oversurges the heart and actually stuns the heart muscle such that it actually balloons out. It can't contract well.
Okay.
That's where this condition got its name. They call it takotsubo because the heart balloons out like an octopus pot.
How often are you seeing that in clinical practice?
Every time I'm on call, I will see an acute admission, probably. So, I'll see it once a week, probably.
Once a week, you're seeing that?
Yeah, at the
from
front end.
acute stress.
Yeah.
And what's the youngest and the oldest patient that might present to you with this?
So with this particular condition, stress cardiomyopathy, takotsubo, there's something about it where there's a preponderance in females and there's a preponderance around the menopause. So
Okay.
As the estrogen levels drop, the heart can become more vulnerable to these stimuli. So there's something about it that tends to peak around that. Not that it doesn't happen in men. It does happen in men. And
Yeah.
it does happen in all age groups. But there is that peak in the sort of 50s in females as some of their protection drops.
So would you say it's in actual menopause, or do you see it as well in that perimenopause?
Perimenopause.
Okay.
Yeah.
Okay.
Yeah. Again, but not that you don't see it in other
Sure.
extremes as well.
Yeah.
So, we brought that condition up to explain really how, stress in overload
Yeah.
can affect the heart.
Yeah.
But obviously throughout the stress spectrum, at a lesser level, stress can affect the heart in a bad way through multiple mechanisms.
Okay, that's very clear. That comes in beautifully because after the break,
Yeah.
we're going to look at the scan you did of my heart.
Yeah.
And you
Beautiful.
had a little look at the coronary arteries.
Yeah.
And let's see how much atherosclerosis there is going on. Okay, so now you very kindly did a scan of my heart, Manny. So what are we looking at here?
Okay, so this is a calcium score CT scan. So what this is a very low radiation CT scan through the chest, okay? And any CT scan or X-ray, what it does is it looks at all the structures within its field, okay? So this is the heart in the chest. Now you can see because bones are full of calcium, so that's your sternum and your backbone, your spine. Because that's full of calcium, it shows up as bright white.
Yep.
Okay. Now, what you don't want to see is any calcium in the heart because the heart, as we explained, is full of muscle, soft tissue, elastic tissue, valves. It shouldn't have any hardening or calcium in. So as I scroll through your heart, there is no bright white substance in your heart at all, which is good news. So there's no calcium in your heart. And more specifically, we'll come back to this in the model after a while so everyone's orientated, but this is the aorta, which gives off the coronary arteries.
Yep.
So this kind of worm here, this round circle that my mouse is on, is one of your coronary arteries, okay?
So the smaller vessels
Yeah, so
are sat there, yeah.
this is your LAD artery, one of your coronaries. And from the other side, this one coming out here, this here, is the right coronary artery. I'm following that all the way through with my mouse now, okay?
I see.
Wraps around the heart there, okay? And then your third artery should be down here. This one is the circumflex artery.
Okay.
None of your arteries have any calcium in, okay? Now, at the age of, okay, if you had any plaque in your coronary arteries, usually they will have calcified, okay? So this is a test that we recommend generally over, the age of 40 or 45.
Okay.
Because if you've got plaque in your arteries, the body responds to that fatty substance by wanting to stabilize it. Okay, so it puts down calcium on the fatty plaque in your arteries.
Okay.
To stop the cholesterol plaque from rupturing. Okay, so the calcium is not actually the enemy. Okay, but the calcium is so easy to see because it's like bone. So the calcium is the footprint of this atherosclerosis process.
Got it.
And we can pick it out very easily. So in conclusion, we've seen no calcium in your heart at all. So I can say your calcium score, your coronary calcium score is 0, okay, which is the best possible result. Okay, we call that the We call that the power of zero, okay?
Okay, so good news.
It's brilliant news, okay? What we can say with a calcium score of 0 is that your risk of heart attack or stroke over the next 5 to 10 years is extremely small, okay? Very low indeed, okay? To the point where if you had other risk factors, this calcium score result almost de-risks those. This is a really important point. When you maybe go to GP or other doctors, or you look at what your cardiovascular risk might be, there's often lots of calculations. Some of them involve your postcode, your family history, all these sorts of things. And you end up with a risk that's based on statistical models. Those are average for the population. But what we've done here is said, never mind the rest of the population, what's actually happening in your heart. So this is personalized medicine. This is your own specific risk. And so this kind of trumps those other models and risk calculations. And that's why it's such a great test to do. And it's so powerful, because if you want to see if you've got coronary artery disease, look at the coronaries. That's the motto of this, of this test. Okay.
Manny, I love it. And exactly, this is the future of medicine, right? The personalized aspect of it. And this is exactly what we're looking at here. Like you've just said, at best, I would say many patients will go into potentially primary care or other providers, and they may do a statistical aspect.
Exactly.
Or some rudimentary measurements.
Exactly.
But again, it's not a clear understanding of that patient. So do you show the images to your patients usually and ask them how they feel about it, or how do you use this?
It's 100%, okay, because you can tell a patient a lot of information, and it can go over the head, but actually showing them their heart.
Yeah.
And maybe I'll show you an example of an abnormal result.
Yes.
And how you can then show a patient, you're not having to convince them that they need medication or convince them that they need intervention. They're seeing it for themselves. So I'll show you a volunteer we've had with their consent. Let's see the real impact of this kind of technology by showing you a different case. As you can see.
Okay, so we can start to see some white at this point.
Exactly. Okay, so you can see how easy these are to interpret as well. There's such a simple, elegant test. Okay, so you can see calcium in the bones.
Yeah.
But this is the heart here. And if you remember, this artery was the right coronary artery here, coming out here. And you can see there's white stuff in it. This is the calcium, okay? And so this indicates that this individual has got coronary atherosclerosis, plaque deposition in their coronary arteries. And the body has responded by calcifying it, by putting this bony calcium down to try and stabilize it, okay?
Okay.
So we asked the computer to highlight the calcium. So you can see it's highlighted the calcium in the bones.
Yep.
And then we can then add this up in the heart by just telling which artery this calcium is in, and it picks it out.
So it's a cumulative score?
Exactly. So let's say, I've been through all the red blobs and added it all up. We then get a total calcium score here, which, as I've left it, is 450. Okay. Now, actually, when I've done the whole analysis in this individual, it's actually over 1,000.
Really?
Okay. So calcium score goes from 0, which yours was, all the way up to several thousands. Okay. So that's the scale of it. Now, what is useful is not only the absolute score, is this percentile score, okay, which compares your calcium score to the general population. So if we take this individual here, let's say this was their score 454. The percentile score is 67, meaning that if we took 100 men of this patient's age, 33 would have a worse score, but 66 would have a better score. Okay,
Yeah.
So that indicates where they stand. So they have more coronary atherosclerosis than average for their age.
How did this patient present to you, Manny? Oh, right.
They looked well. They walked in the department. They walked out. So these are individuals that have engaged in primary prevention, and it just shows that you don't know what is in your body. If we calculated this individual's conventional statistical risk score, they live in an affluent area, postcode goes into these statistical models, so their risk was actually quite low, by traditional models. But as soon as you do this, you see actually that was false reassurance, the appearance and these average population models. this patient's individual risk, having looked at their heart, showed that they were high risk.
How fascinating. So when you first saw the patient,
Yeah.
do you have any kind of preconceived ideas or expectations of what the calcium score is going to be or what their CT is going to look like?
So when you see an individual with lots of risk factors, let's say a smoker, high cholesterol, sedentary, strong family history, you're pretty much expecting to see something, okay? And if you see someone who's very healthy, usually, you're hoping that it'll be low or normal. And then there's that huge chunk in the middle, okay? Most of us do have a risk factor if we think about it, okay? Or we pick one up in our lifestyle, in our life. There's no way around that. So the Cal score is really good at dealing with that bunch in the middle that would conventionally get called intermediate. Intermediate to me sounds a bit unsure. Okay, what do they do with that? Do I relax about that? Do I worry about it? So again, looking at an individual's personalized risk is really useful. Okay.
So Manny, what we're looking at now.
So what we're looking at now is another step in the cardiac CT process. So yourself and the previous example I showed had a non-contrast calcium score. Now there is a second part or an add-on test that we sometimes do. We mainly reserve this for patients who have chest pain. Okay, it's called a CT coronary angiogram. So it's to look directly at the arteries, not just for calcium, but also for plaque that has not yet calcified. So the fatty plaque. Okay, which is the more dangerous kind of.
Is that a step before it's calcified?
So all plaque starts non-calcified, and then your body responds to that plaque, the fatty plaque, which it doesn't like, by trying to stabilize it by putting calcium down.
Yeah,
okay?
got it.
So there's two types of plaque: non-calcified, which is more prone to rupture and cause heart attacks, and that evolves into calcified plaque once your body has had a chance to stabilize it. Okay,
such an important point.
And then there's a group in between, which are in transition, if you like. They're mixed plaques. Okay, so if we look at this patient, so we've given the patient contrast to look at the heart in a bit more detail, and we get this beautiful kind of 3D image of the heart, and we can actually directly look at the artery. So if we look at their artery down the front, what we call the LAD, if I bring that here, you can see this plaque right here, this narrowing. Okay, I'll make that a bit bigger for you. You can see how the contrast here is flowing through the artery, but it pinches down here. So this is a severe pinch or stenosis in this artery. So that accounts for their chest pain. Okay, the heart muscle can not get enough blood because so much plaque has built up here that it's narrowed the artery. The body's done its best. You can see this plaque is a bit calcified, but this section here is not calcified. That's fatty plaque that could rupture, or this stenosis could completely occlude this artery. And this is a big artery all the way down the heart. So all this heart muscle here would not get enough blood and would die, which is a heart attack. Okay.
Yeah.
So this is how far technology's come. We can look directly at your arteries, and we can give this patient a precise diagnosis. We can also give them a precise risk, because we've seen the plaque in all their arteries. Any artery, we can look at. So we can ask to look at the artery on the right, and in this artery, you can see they've just got a little bit of plaque, calcified plaque here, but the rest of the artery is okay. So we can go through all their arteries iteratively like that and give them a precise diagnosis and risk.
It's very clear, and it's very interesting, and I think it's so useful for such a spectrum of listeners. Because you do see outliers, right, where you'll see a younger patient potentially with other risk factors that you could then scan, get this objective measurements, and give them very clear lifestyle modifications.
Yeah, I think that educating the patient is key. So when I show a patient this, they believe they have a problem, okay? By showing someone their heart in a relatively quick, simple test, showing them exactly what the problem is, it motivates them also to do something about it.
Absolutely. Yeah, really helpful.
So, I mean, you've had the test. So how was it from your perspective? What did you think of the results?
So I thought the test was so much easier than I thought it was going to be. I literally went in, a few ECG leads on me, went into the scanner, held my breath a few times, and went home. Yeah. So I thought it was a super straightforward test. In terms of the results, I was actually quite shocked, Manny. I was quite shocked. I don't know what I was expecting, but I think I was expecting to see something. I found it really reassuring, actually. I actually really love to see it as well. And I think that would be, I can just see it as being such a useful adjunct when you're in clinical practice.
Yeah, definitely. I see patients' faces and I show them the calcium. You can see their motivation completely change because they've seen, in their own body that there's something and they want to tackle it, they want to fix it, they want to get it right. So even as a motivational tool, at a screen level, it's very important.
Motivational tools are so helpful, right? How can people access the calcium scan?
So you find that most people are doing this privately. Not that it couldn't be requested within, NHS for the right patient, the right circumstances. So generally, this test is for individuals who are over, men over 40, females over 45, with at least one cardiovascular risk factor. And so the main cardiovascular risk factors we consider are high blood pressure, diabetes, family history, smoking history, or a sedentary lifestyle. Okay. So if you have any of those risk factors and you're over 40 or 45, then you could ask your doctor, your GP about a calcium score, get a referral for them. Some places that will happen within the NHS. Sometimes you can go to a private clinic, but it's really quick and simple to do.
I love it. I guess I have one final question for you.
Okay.
What does feeling ageless mean to you?
Feeling ageless. You've sprung that one on me.
Yeah, I have.
Feeling ageless. I think being able to, go through your daily life without having this age anxiety, okay? Because I think Mariah Carey recently said age is optional. It is optional to some extent. We can't stop our telomere shortening. It does happen. It's a physiological process. But we can modify it, okay? We can keep ourselves healthy. We can optimize our fitness. We fall into this trap of thinking when you're old you can't do X, Y, or Z, but we can, keep ourselves healthy as long as possible. We can instigate prevention at a very, early stage to prevent getting diseases.
Yeah.
So I think the whole age-less concept is I'd put the emphasis on less, and it's age less, okay?
So that's how you say it?
Exactly.
Okay.
So slow the process down as much as we can.
Well, thank you for objectively helping me personally with this today.
No problem.
And for all those beautiful educational insights. As Dr. Motwani has so powerfully reminded us, what we don't see can hurt us, and what we assume about our fitness, our family history, or even our youth may be the greatest risk of all. But knowledge is agency, awareness is prevention, and prevention is the most profound expression of longevity. So what can you do today? First, know your numbers. Take your blood pressure, check your resting heart rate, and if you're over 40, ask your doctor about the scan we discussed today. Second, move daily. Even 7,000 steps can shift the trajectory of your heart health. I often describe the heart as an important part of the ecosystem that holds our emotional compass and our bridge between inner and outer life. If you found this conversation valuable, please subscribe, share it with someone you love, and let us know the questions that you want answered in future episodes. And as a thank you for being here, you can redeem an exclusive free skin consultation and 15% discount on the One Dermafacial with my team in my clinic, One Aesthetic Studio. Simply follow the link in the show notes and enter the code HEARTHEALTH15 at checkout. And so I leave you with this reflection. What one choice will you make this week that your future heart will thank you for? I'm Dr. Jonquille Chantrey, and this has been Ageless.